we're going to talk about triage and what we've learned and all those kinds of things. What you have on here, the name, age, height, weight, blood pressure, oxygen sat, temperature, pulse, and respiratory rate are all critical items, obviously. Now, the MUAC, target weight score, activity, playing, appetite, vomiting, and diarrhea are not really worthy of this initial triage because, you know, when we're talking malnutrition and things like those are kiddos that are going to be admitted unless they're in such distress because they're hypovolemic, you know, and they have a low blood pressure. Are they going to be emergent? So these things, the MUAC, the target weight score, activity, playing, appetite, vomiting, diarrhea, all can be removed from this. And this is why I'm saying that. This is your triage, right? This is what we already learned. We know that when a mom is walking up to us with their baby, we're looking at this triangle. We're looking at that baby, at their appearance. We're looking, are they interactive? Are they alert? Are they lethargic? Are they inconsolable? Are they not breathing? You know, there's their appearance right there. So when you go back and you talk about activity playing, we're hitting this with the appearance. They're lethargic, they're inactive, whatever. Work of breathing. Are they retracting? Do they have supraclavicular, subclavicular, suprasternal, intercostal retractions? Are they working really hard to breathe? Are they leaning forward and tripoding because they can't breathe when they're lying down? The babies, are their noses flaring? Those are all things that we're looking at. We're not even touching our patient. Because you guys are so good at this and you're so experienced, you know sick from well. You know level 1 is the kid that's being carried in unconscious, right? That's your level 1, goes right into the ER, and you basically will fill that paperwork in afterwards. It's the level 2 and 3 that you want to differentiate, but I'm going to add a 4th one for you because the 3 just don't encompass them all. So when you go back and this was your triage, you have a lot of information on here you don't need to have in your triage documentation. Number 1, level 1, do they require immediate life-saving intervention? We've had so many kids that just come in and offward to the races. We're putting in the IV, we're doing resuscitation immediately. Obviously, that's your priority 1, admitted directly to the ER and gets to stay there. If the answer is no, okay, you have to ask yourself, though, from that appearance, from that PAT, is this a high-risk situation? And what we're talking about, this is called an emergency severity index. In some of the paperwork I sent you, that's what they're calling it, an ESI, but it's just basically your level 1, 2, 3, or 4. Simple to use. They recommend 5 labels. We're adapting it to meet your needs at Whispers with 4 levels. So if the patient doesn't, need this, go directly in for emergent treatment, are they a high-risk situation? Are they confused, lethargic, or disoriented? And then are they having severe pain or distress? So for example, a burn patient who comes in with all of, like the couple of burn kiddos that we had while I was there, that obviously wasn't so much life-threatening, but the patient was in severe distress, was in severe pain. These would be a level 2 observation, and this is your ED admits for the 24 hours. These are still your really sick kids, but in triage, you can still gather the information before you bring them into the emergency room for their bed, is what I'm saying. So a level 1, you run them right back into the ER. You'll get that paperwork as you do that, right? Level 2, you can complete, just think of our little girl we had with the burns that first day we were there last month or in March. She easily could be triaged right there and get the information and taken into the emergency room for the treatment. The acuity is determined by the stability of the vital signs also. So they've given us a really good, and again, we always are talking about using evidence-based resources. So let's say they don't need this run right back there. It's not exactly a high-risk situation. They're not showing all of this, but hey, their vital signs are in the danger zone. Okay, so then you experienced nurses need to determine the difference between this level 2, which basically means you're going to get those vital signs, get all your history and physical for that triage assessment, and still get them directly into the emergency for the nurses and doc in there to see and evaluate. So that could be a 2. So if the vital signs fall outside, these ranges and they're in the danger zone, but you think they might be able to wait an hour or so, you can make them a 3. Okay. Really, a 3 is anyone else who's admitted to your hospital outside of the emergency room.
I have a question.
Yes.
About the danger zone vitals, the danger zone vital signs.
Yes.
What would you consider the critical oxygen saturation?
Anything below 92 for oxygen saturation.
Have a cut of 94% as our critical value. If we adjust to 92%.
Yes, if the pulse oximeter is less than 92%, then I definitely would consider making them a 2. If, let's say, again, here's an example, Walter, if the patient comes in with a 94%, maybe it's an asthmatic, right? Someone who has asthma and they're in exacerbation and they come in and they're at 94, but you're going to give them a nebulizer and maybe this is a patient who's been here before. They are in a danger zone, right? Because 94 isn't where we want them. We want them to be at 98. However, is it a level 2 or is it a level 3? That's where your expertise as triage nurses is the big difference maker. I worked with a lot of nurses who would err on the side of caution and make them higher, elevate their priorities, and others who would not make them higher and they would downplay the significance of the illness. So it's really a danger zone for all of us to be very, very cautious. If you think, basically when we're in the ER in the States, a level 1 goes right into the trauma suite, no waiting. A level 2 in our mind can only wait 20 minutes. So that's kind of your thought process when you're thinking about a level 2. You've got about 20 minutes. With an asthmatic who is in exacerbation and wheezing or very tight, you don't have much time to intervene, but you do have at least 20 minutes. You have 20 minutes, get your vital signs, your blood pressure, your weight, your height, get your basic history and get a nebulizer and some oxygen on your patient. You can do that as a level 2, and it gives them about 20 minutes. A level 3 is something, could be a broken arm, a wound. A level 3 is something any patient comes to Whispers needs to be seen, absolutely, but it's not emergent. It's not life-threatening at this moment or will not be this day. But they do need admitted. They may have an infection. They may be malnourished. They may need to be admitted for nourishment. They may have acute gastroenteritis and they're dehydrated, but they're not so dehydrated that they're hitting the danger zone vital signs where they would be a 2. But yes, you feel like, well, they're dry enough. They're going to have to come in and get some IV fluids, even if it's for several hours, and that's somebody, the level 4 is someone who really you just see and discharge. They came in, the baby was colicky or crying and irritable and, wasn't eating or something, and they were given something to, make them more comfortable and sent home. That's your category 4. So when your kids come in, with their first complaint of why they're there, you're going to start that process. But for the purpose of this, does this help describe between the 2 and the 3 how critical your assessment skills are as the triage nurse? And you want to co-validate your scores. I know I worked with some nurses that were just awful at this. They were terrible. They had everybody a 1 or a 2. They never even had a 3. It was like, you've got to be kidding. We see 300 kids a day at that ER. And this one triage nurse was giving us all 1s and 2s. And we were like, these are not 1s and 2s. You're not doing this right. So collaborate with each other. When someone opts in triage for a score that's a 3, and say, Walter, you went and got the kid to bring the kid back to be evaluated, and it's a 3, and you look at the kid and say, oh no, this kid's a 2. This is why. You always want to go back to your triage nurse and say, hey, it might have been the 20 minutes between when you saw the child when they arrived and they were a 3, but now when I go to get the child, he's a 2. You have a responsibility and obligation to share that with the triage nurse in a positive way, because it could have been 2 reasons. First reason is the child just deteriorated naturally in that 20 minutes to when you got them. Or the second thing is they really didn't assess the child properly, that the child should have been bumped up or should have been dropped down. So just be very open with your communication as you use the new tool, and you're going to make it what's appropriate and works best for you. Remember, reiterate the process, the point of triage. It's a quick, efficient assessment of just where the people need to go. That's it. It's just, that's what's so good about it, is it helps you, because you don't need to gather all this information the first time you meet them. You're going to do an admission history and physical when they get in. This is just to determine, are they going right in? Are they going to wait? Or are they going to wait longer? 3 things,